Good afternoon to all. Welcome to our second session. Today we are having a topic on introduction to pain and it will be taken by Dr. R Rajagopal. So we can start with sir's presentation. We can have it for around 40 to 45 minutes followed by 15 minutes of discussion. By 4 we can have our case presentation followed by its discussion. We can wind up our session by 4:30. Thank you all for joining in. Over to Dr. Sunil.
Thank you, Rajalakshmi. So today we have a very important session which is a common symptom which is seen in not only in cancer but also in many other diseases. So pain is one of the most common symptom in cancer patients, but it is also common in many other diseases. Rajagopal sir will be talking about basics of pain and as I told you earlier, he is the chairman of Palliative India and director of Trivandrum Institute of Palliative Sciences. You will hear more about pain from him. Sir, it's over to you.
Thank you, Sunil. Thank you, Raju. Hello, everybody. It's afternoon to most people, evening for some people from some countries. I hope you are enjoying the course and that our sessions so far have been useful for you. The other day, when I introduced palliative care, I did mention that physical issues are only part of the problem. Social, mental, spiritual, everything matters. Having said that, pain does matter. And this is what I will talk to you about, generally about pain. And about how important it is to understand pain and what are the basic lessons that we must have to manage pain. I introduced this man to you last time itself, but not by name. This is not his real name. He had advanced cancer of the cheek. He had refused treatment at first because he was told that he'll have a facial deformity and because he could not afford the surgery anyway. And now it's incurable and he is in agonizing pain. Let us all remember that the magnitude of pain can be beyond your ability to imagine. What a person with the cancer of the cheek, another man like him told me was, what he felt was like somebody putting a nail into his ear and driving it with a hammer. And that was going on and on. I can't even imagine that happening to me once. Now, this is one thing that we will remember. Though we said that problems are physical, social, mental, spiritual, and everything, pain can be so all-consuming that it leaves little mind space for anything else. You forget the worries of your spouse, you forget the worries of your family, children. You are concentrating only on your pain. And this, okay, in everybody it is not excruciating like that, but in many conditions like cancer, peripheral vascular disease, some neurological problems, and so on, it can be unimaginably cruel. Last month, in July 2020, the International Association for Study of Pain revised its definition of pain. It was very similar, and that, oh my God, that was 41 years old definition has been modified, and I have given the link there so that you can look at the document there with some footnotes. Now, that's a very long definition and rather confusing. Unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So let me just mask some parts of it. It's still there. Essentially, it's about recognizing that pain is not only a sensation, that it is also an emotional experience associated with tissue damage. I'm not going into why all that rest of the confusion is there. Say, if you think about somebody with a phantom limb pain, you can imagine why those additional wording is there. But here it is. If you prick your finger with a pin, the sensation is certainly painful, but how you react to it is another thing. If somebody is doing that in anger to hurt you, your anger and your upset feeling, everything magnifies your experience. But first about the sensation itself, and then we'll talk about the rest of it. Let me use that picture at the bottom as a super simplified pain pathway. So if you, this is the peripheral nerve ending. So when you are pricking your finger with a needle, the needle and the injury is going to stimulate peripheral nerve endings. Let us call them the nociceptors, the receptors perceiving the noxious stimulus. The nociceptors are stimulated, generating an electrical impulse, which passes through the peripheral nerve onto the dorsal horn of the spinal cord, where the impulse gets modified for onward transmission to the brain. Reflex responses to the pain like muscle spasm will occur at the spinal level, but appreciation of pain occurs at the brain. Everybody okay with this? I'm not going into the neurotransmitters and the brain pathways. We are trying to understand what is most relevant to us. And here is a question for you. If that stimulus continued constantly, if instead of taking the needle away, somebody was pricking your finger again and again and again with a needle, and that goes on and on and on, will it cause the same pain? Will the pain increase or will the pain decrease? Except in the mildest pain, where emotionally you may get acclimatized to it. Okay, my neck pain. Oh, it is just a little
There
bit.
are few comments.
In the chat?
Yes, sir. Somebody says it will decrease, and many says it will increase.
Okay, thank you, everybody. Everything, both answers are correct. It will decrease only in the mildest of pains. As I was saying, my neck pain, I know it is a mild cervical spondylosis. It has been the same for the last 22 years. I'm not worried about it. I hardly think about it. Emotionally, I've got acclimatized to it because it is not severe and because I am not worried about it. But think, why is pain there as in the body? What's the purpose of pain? It is to protect you. When you prick your finger, you withdraw with the pain. And that is a reflex that protects you. And if you are not running away, like Joseph has cancer, and the body keeps telling him, Joseph, that is torturing you, run away from it. Joseph cannot run away from the cancer. But the body doesn't know that. Body keeps on warning Joseph, more and more and more. So for any significant pain, except the mildest, as many people of you said, pain will keep increasing. And we are going to talk about the mechanism of how that happens. One, the nociceptors themselves get both recruited and sensitized. The recruitment means there were the nociceptors in my previous diagram also, not all that many, but here silent or sleepy nociceptors, like the reserve police called in when there is a riot, they are called into action. That's called recruitment. What's the result? More nociceptors, more pain impulses. Secondly, the receptors also get sensitized so that for the same stimulus, the number of electrical impulses will be more. So recruitment and sensitization of nociceptors means that pain will keep increasing. And if you decrease the sensitization by prostaglandin inhibition, there will be reduction in pain. To some extent, the process of worsening will be avoided. This is what you achieve with your ibuprofen or any NSAID. They block prostaglandins. So thereafter, even the kinins or the hydrogen ions or the potassium ions, any substance P, etc. are less effective. Okay. Hey, ladies and gentlemen, so we have mentioned one way in which pain causes more pain. That's by recruitment and sensitization of nociceptors. Okay, but that is not the only thing. In fact, something else can be even more important. That is not only the peripheral sensitive recruitment, but adjacent spinal segments are also recruited. What I mean is, if I have a fracture of the rib here, today my pain will be very focused there. But tomorrow, my whole chest will be in pain. Again, body is increasing the area of pain. But even more importantly, there is a process called central sensitization. It's also called the wind up phenomenon, like winding a spring up. Here, if the impulses continue to come more and more and more, sensitization here, impulses are continuing to come. At some point, the dorsal horn cell seems to get confused and also sensitized. Sensitization is caused by neurotransmitters, and particularly N-methyl D-aspartate, NMDA. N-methyl D-aspartate seems to be the neurotransmitter that is most responsible for central sensitization. Now, once dorsal horns are sensitized, and we will talk more about it when we talk about difficult pain on another session. But remember that if this has happened, NMDA blockade may be very effective in achieving pain relief. All the anesthetists in the group will immediately identify an NMDA blocker that we can use. Ketamine is an example. There are others, but ketamine is the most effective. The anesthetic agent ketamine, given in subanesthetic doses, can control central sensitization. So friends, once more, peripheral sensitization of nociceptors, recruitment of new silent and sleepy nociceptors, recruitment of adjacent spinal segments, and central sensitization. The list is not complete, but I am stopping there. These are the most important things. These are the reasons why pain may cause more and more and more pain. Hey, why did I bring up all this confusion to you? I mean, okay, I mean, honestly, I have tried to keep it simple, but still, it's quite a lot of pathophysiology. Why? Why did I bring it up? What lesson do you learn from it?
Acute pain, if untreated, can go on to become chronic pain in these patients.
Very good. Who said that? Can you give me
This
your
is
name?
Dr. Uma, sir.
Uma.
Yes.
Thank you, Uma. You are absolutely correct. Let me add on something. Pain, if it is not treated, can keep on increasing. Even if it doesn't become chronic pain, out of 100 people undergoing uh, sternotomy for a coronary bypass graft, only 2 or 3 may end up with a chronic pain. But that doesn't mean that they don't have a problem. During the phase of recovery, they were in agony. So, untreated pain causes worsening of pain, and in some cases, as Uma said, it can become a chronic, long-standing pain that is possibly because of central sensitization, but there is also more happening there. So many impulses, and it's like a total traffic jam, and the morphology of the dorsal horn changes. You have studied the laminar arrangement in your physiology. All that goes. So when this happens, yes, as Uma said, it can become chronic, but even if it doesn't, the suffering can keep on increasing. Therefore, the lesson is this: treat pain early. Don't laugh at pain, treat pain early. In continuous pain, analgesics should be given on a continuous basis, depending on duration of action of each. That means if you are in the habit of using analgesics SOS, one tablet SOS, remember that for a continuous pain, that is irrational. A continuous pain has to be treated on a continuous basis. That means if I am writing paracetamol, it will be prescribed every how many hours? 1 TAD is not enough.
4th to 6th hourly.
Okay,
4
very
to
good.
6 hourly, sir.
Very good, very good. In acute pain, you may give it 4 hourly. Your routine can be 6 hourly.
6 hourly.
Similarly, if you are prescribing morphine, the ideal may be 8 hourly. And so ibuprofen. What did I say? Did I say morphine? Ibuprofen, it would be 8 hourly. For morphine, it would be 4 hourly. Immediate release morphine. So these are the 2 learning points, most important learning points from all the pathophysiology that I mentioned so far. Shall I move on? Or do you have a quick question now? The pain that is caused by stimulation of the nerve ending, nociceptor, is nociceptive pain. Nociceptive pain. The pain that is caused by abnormal impulse generation anywhere in the nervous system is neuropathic pain. Your finger, pinprick with a finger, caused a nociceptive pain. But if abnormal impulse generation occurs in the nervous system, that causes neuropathic pain. Who wants to give me an example?
Diabetic neuropathy, sir.
Diabetic neuropathy, very good. Another one, somebody else?
Brachial neuralgia.
Yeah, but very common after a bad brachial injury. There are other reasons also. And it can also happen with cancer. You have a cancer in the upper lobe of the lung, erodes into the brachial plexus, and patient complains of pain all over the limb. There is no pathology in the limb. Pathology is here. So trigeminal neuralgia. Your disc prolapse. all the disc prolapse and radiculopathy, all these would be examples of neuropathic pain. We mentioned that because it is very important in the management. Unfortunately, very many neuropathic pains cannot be easily treated with the measures that you may use for a nociceptive pain. And also one small point for the future, this neuropathic pain that I have shown, if it is from this point up to this point, that's the peripheral nervous system, right? If it is in the spinal cord or in the brain, that is central, peripheral and central. All the most of the examples that you have mentioned so far are peripheral neuropathic pain. Trigeminal neuralgia may be central. A post-stroke pain is a central neuropathic pain. And anywhere in the pathway, pain pathway, if there is an abnormality like destruction with a hemorrhage or a thrombosis, that causes central neuropathic pain. I mentioned that not for management today, but that also makes a difference in the management. So friends, what we have said so far, after talking about the need for early treatment and continuous treatment, is about identification of the type of pain, whether it's nociceptive or neuropathic, so that we can treat it better. Well, in that context, how do you diagnose a neuropathic pain? I mean, again, there is no scan that can help you. Unfortunately, no investigation can show it very clearly. Nerve conduction studies may give a clue, but will not be diagnostic, unfortunately. So, try to remember these three things. Hey, everybody wake up. Three manifestations of neuropathic pain. One, the quality of pain. Burning, shooting, lancinating, aching. Remember, these may not be absolutely diagnostic. Nociceptive pain can also be aching, but typically descriptions like burning, shooting, lancinating, aching, pricking, etc. are more common with neuropathic pain. And secondly, it will be in the area of distribution of a nerve or a group of nerves. Uma mentioned diabetic neuropathy. That wouldn't be in the area of a distribution of a nerve, usually unless it's diabetic monoradiculopathy. Usually it is in the periphery. Wherever there is ischemia, if the nerves, it causes neuropathic pain. You mentioned brachial neuralgia. Yes, that's an example. Or the disc prolapse and radiculopathy. And thirdly, because the dorsal horn morphology changes, as I said, with time, there is abnormal sensation in the area of pain. Hey, can you try to remember these three things mentally? Make a mental list. Have it ready. Next time your patient comes, you think, is this nociceptive pain or neuropathic pain? Or it can also be very commonly a combination of both. The patient with the upper lobe lung lesion has a local nociceptive pain and a neuropathic pain elsewhere. Similarly, any pain can be a combination of both factors. That also we'll remember. Everybody happy? Can I move on a little bit more? One of the things in assessment that we mentioned so far was a distinction between nociceptive and neuropathic. This image on the screen shows a few things that you will look for when you are when you are assessing a patient's pain. I mean, except for you and all who have an interest in pain, usually what I used to do based on my MBBS, whatever my boss in medicine or surgery used to prescribe, I also used to prescribe. It would be, in some units, it will be NSAID for everybody. In some other units, it's tramadol for everybody. It's strange that doctors who practice strictly evidence-based medicine for everything else become rather quacks when it comes to treatment of pain. So this PQRST is a sort of mnemonic for you. P, what provokes the pain? The patient says, whenever I move, even the slightest movement causes the pain. That's important for us. Maybe there's a pathological fracture. When the patient says, since yesterday after I coughed, I have agonizing pain when I cough. And even when I take a deep breath, it is severe pain. Again, it could be a pathological fracture of the rib. What relieves the pain? It's an important information. The quality of pain, we already talked about it. Depending on the quality of pain, we can make a difference. Burning, aching, pricking, lancinating, etc. we said were typical of neuropathic pain. We need to understand that. Radiation may give the only clue to the site of origin of pain, like a shoulder pain, tip pain in diaphragm involvement, or a McBurney's point pain in an appendicitis. That's important, obviously. The site of pain, what we, Sunil and I and everybody at Palliative India routinely do is for every patient with pain, every patient, we mark it. So for that person with chest pain, we will mark it here with a particular shade and also mark the whole of the upper limb, indicating this will be pain 1, this will be pain 2. If they are different, we will mark them separately. Because next time patient comes, it's important for us to remember what was the condition last week. So it is marked on the body chart routinely. Severity also is marked. So you see the panel on the bottom. This is what we routinely use. There are other tools that can be used. I'm not saying that everybody should use a numerical scale. Let's not get confused. This is not a visual analog scale. Visual analog scale doesn't give the numbers in front. This is a numerical scale. What is 0 is no pain. 10, worst imaginable pain, worst possible pain. And you ask the patient, how much pain did you have? And the temporal factors related to time. Is the pain for all the time? Is it continuous, intermittent? How long have you had it? When does it get worse? Etc. So routinely, these are things that we write. What is missing? There is one huge thing missing. So far, everything that I said was about the sensation. Pain is not only a sensation, it's a sensory and emotional experience. So one important point left over is an assessment of what is the effect of the pain on the person. I showed you IASP, International Association for Study of Pain definition earlier. The same definition has a footnote saying pain and nociception. Nociception is that stimulation of the nociceptor and the process of the impulse traveling to the spinal cord and onto the brain. and feeling the pain. So pain is not only nociception. Pain is also the emotional experience. So just measuring the activity in a sensory neuron doesn't give you an idea of the pain. Have that very clear. The most important thing is to recognize that emotional issue is not the person's fault. It is for us to identify and do something about it. Sunil, you have something to say? Sunil seems to have raised hand. No.
No, sir, it's by mistake.
Okay. The same IASP definition also has another footnote. There are 5 footnotes. I hope you will look at them. But the other one is, pain is a personal experience. My pain is my experience. Dr. Rashmi cannot understand my pain except through my words. You cannot do a scan, and there is no way for Dr. Rashmi to understand my pain except by listening to me and by believing me. Biological, psychological, social factors all can worsen it. And this becomes particularly important in the patient suffering, as was described by Dame Cicely Saunders. Most of you, I am sure, know Dame Cicely Saunders, but for anyone who doesn't know her, Cicely Saunders is the pioneer of the modern hospice movement. The whole palliative care, the palliative care that we are talking about was all created by this guru, Dame Cicely Saunders, who died 15 years back. Cicely Saunders said that pain is a conglomeration of physical, social, emotional, and spiritual factors. You will also notice that each circle is encroaching onto the other. Emotional problems cause physical pain. When you are stressed, that's why some of you get a headache, some of you get a low back pain, and some of you get a neck pain. If you are quarrel with your spouse and have not slept well, that precipitates many of your muscular pains tomorrow. And if I have a feeling, spiritual anguish, what's the point of my being alive? I might as well be dead. Then that's going to affect all the other domains of suffering, including physical. So remember that in total pain, all these 4 circles are intertwined and they affecting one another. But let me also remind you of one point. Cicely Saunders created it. And when we follow it, we have to remember that social includes financial. Social includes financial. We live in a country where there is a lot of poverty, where 55 million Indians are pushed below poverty line. I mentioned that last time, remember? 55 million Indians are pushed below poverty line in a single year. And that has to be remembered as part of the problem. Before you write your prescription, think of the cost of the medicine. What we carelessly write may deprive the child and the family of the next meal. This is not theory. This is something that happens every day. Time and again, I see people buying your multivitamin mineral preparations and going hungry. So this is the concept of total pain. I'm going to show you a video where one of my colleagues, she's a psychologist by training. Her name is Smriti Rana. And last year, she gave a TEDx talk at St. John's. So this is a clipping from that video. After you have listened to it, my talk is over. And then we will still have quite a bit of time left, 20 minutes, to discuss all this.
In palliative care, we have this notion of total pain, pain that takes into account the life circumstances of the patient that contribute to his or her experience of suffering. I came across that concept quite early in my life, and I mean, in my career, and I thought I understood it, theoretically at least. And then one day, the home care team that I was a part of was called in to see his fishermen in one of the outlying villages of Trivandrum. We parked our van some 400 meters away, made our way down this narrow, undulating path. We could hear this man's screams well before we got to his house. And on approaching the house, we were assaulted by the stench, which made me gag. And when we entered his home, we were met by this helpless young woman, and behind her on the bed, a man in his 40s, who was the source of the screams. He had a myriad problems and a feeding. And on closer examination, we found that he also had a bowel obstruction that was not allowing him to pass what his wife was so diligently feeding him because she didn't know what else to do to look after him. And as a result, he was regurgitating his own waste. It was awful. Anyway, he was cleaned up, analgesics and other medication were administered, but no matter what we did, his pain would not fall below 6 on the pain scale, which is essentially a scale of 1 to 10, 10 being the highest, where we ask people to score their subjective pain. So finally, this benevolent and wise doctor that I have the absolute privilege of calling my mentor, he took this man's hand in his own and he asked him, he said, "What's your biggest concern? What is bothering you?" What an odd question, I thought. I mean, the pain, the humiliation, the despair, and just the misery of everything that he was experiencing. I mean, the answer was glaringly obvious to me. The man didn't say anything for a long time, and I started to get fidgety. The silence was starting to get awkward and strained, to me at least. But the good doctor, he held steadfast. And after about 6 long minutes, and I know this because I was timing it, this man very softly said, "All I wanted was for my children not to be fishermen. And now they're going to be just that." He knew he was dying, and he knew that his wife would not be able to support the children on her own. And this one fact was causing him far more agony than anything else that he was going through. So one of the things we strive to do in our program is to undertake the educational needs of children from disease-ravaged families that can no longer afford to send them to school. But this process takes about a week from when the child has been identified. In this case, however, we sped up the processes. Donors were found, pledges were made, documents were signed, all to see these 2 children, aged 8 and 10, through to college. We returned to the fisherman's house the next morning, and he was asked what his pain was. He was then shown the documents, and he was told, "It is done. Your children will not be fishermen." The transformation on that man's face was magic. And once he had digested that information, he was very gently asked one more time, "What is your pain now?" He died 3 days later, pain-free. And that, my friends, is total pain. And that was when I truly learned my first lesson in being still and allowing it.
Hello. Friends, that was Smriti's description of total pain. I conclude my talk with that video with Smriti's demonstration. Sorry.
Sir, that video was not clear. Voice was breaking, and sometimes it was very feeble. So I don't think
Oh,
anybody
I'm
have
sorry.
had it clearly.
Oh, I wish. Smriti, sorry, Raju, we do have the time. It is only 3:40. You have the video there. Do you think you would like to show it? It is only 4 minutes, so that's okay.
Yes, sir, I will show it.
My apologies, everybody.
Sir, I think it is okay. You can just mention the crucial part. If you can just mention the crucial part, maybe we can understand. He was having a lot of physical pain, but the emotional component, if you can just mention that again, it will be very clear, sir. That's the children's part.
Yeah, doctor, thank you very much. Raju, are you ready with it or?
Yes, sir, I'm ready with it. Can I share it?
Yeah, I think so. It's only 4 minutes rather than try to find the appropriate part. Maybe it will be a good investment of time.
Of care, we have this notion of total pain, pain that takes into account the
I hope it is clear for everyone now.
Now it's clear, Rajlakshmi.
It is clear, ma'am.
life circumstances of the patient that contribute to his or her experience of suffering. I came across that concept quite early in my life, and I mean, in my career, and I thought I understood it, theoretically at least. And then one day, the home care team that I was a part of was called in to see this fisherman in one of the outlying villages of Trivandrum. We parked our van some 400 meters away, made our way down this narrow, undulating path. We could hear this man's screams well before we got to his house. And on approaching the house, we were assaulted by this stench, which made me gag. And when we entered his home, we were met by this helpless young woman, and behind her on the bed, a man in his 40s, who was the source of the screams. He had a myriad problems and a feeding tube. And on closer examination, we found that he also had a bowel obstruction that was not allowing him to pass what his wife was so diligently feeding him because she didn't know what else to do to look after him. And as a result, he was regurgitating his own waste. It was awful. Anyway, he was cleaned up, analgesics and other medication were administered, but no matter what we did, his pain would not fall below 6 on the pain scale, which is essentially a scale of 1 to 10, 10 being the highest, where we ask people to score their subjective pain. So finally, this benevolent and wise doctor that I have the absolute privilege of calling my mentor, he took this man's hand in his own, and he asked him, he said, "What's your biggest concern right now? What is bothering you?" What an odd question, I thought. I mean, the pain, the humiliation, the despair, and just the misery of everything that he was experiencing. I mean, the answer was glaringly obvious to me. The man didn't say anything for a long time, and I started to get fidgety. The silence was starting to get awkward and strained, to me at least. But the good doctor, he held steadfast. And after about 6 long minutes, and I know this because I was timing it, this man very softly said, "All I wanted was for my children not to be fishermen. And now they're going to be just that." He knew he was dying, and he knew that his wife would not be able to support the children on her own, and this one fact was causing him far more agony than anything else that he was going through. So one of the things we strive to do in our program is to undertake the educational needs of children from disease-ravaged families that can no longer afford to send them to school. But this process takes about a week from when the child has been identified. In this case, however, we sped up the processes. Donors were found, pledges were made, documents were signed, all to see these 2 children, aged 8 and 10, through to college. We returned to the fisherman's house the next morning, and he was asked what his pain was. Still 6, he said. He was then shown the documents, and he was told, "It is done. Your children will not be fishermen." The transformation on that man's face was magical. And once he had digested that information, he was very gently asked one more time, "What is your pain now?" 1. He died 3 days later, pain-free. And that, my friends, is total pain. And that was when I truly learned my first lesson in being still and allowing.
Okay. We started this by defining pain as a sensory and emotional experience. We went on to the sensory part of it in some detail, mentioned several ways in which pain becomes self-perpetuating, worsening itself, and including central sensitization. Arising from that, we went on to describing, identifying two principles: treat pain early whenever possible, and in all continuous pains, give analgesics by the clock so that the analgesia can be continuous. And then we went on to classify pain into nociceptive and neuropathic. And in neuropathic pain, we identified three major diagnostic points: the quality of pain, like burning, etc., the distribution of the pain in distribution of nerves or groups of nerves, and abnormal sensations in the area of pain. And we also mentioned that pains can be both nociceptive and neuropathic in the same person. And then we brought in the concept of total pain and saw the video of Smriti's description of her own encounter with a total pain. So friends, now it's a time for discussion.
So thank you, sir. If any of you have any questions, please ask now.
Hello, sir.
Hi.
Yeah, sir, I am Dr. Shodhi. Sir, what about the spiritual pain, sir? Spiritual pain.
Okay. Suppose, we will, this is a foundation course, but we do have a session on spirituality, right, Sunil? Raju?
No, sir. No, sir.
No,
We
okay.
don't have.
Okay. Thank you. I don't know what that spirituality means to you, but everything that is not material that is important to a person is part of his spiritual makeup. Specifically, the values, my values in life, my connections, what connects me to this universe. It is partly my home, my family, but also Pallium, the people that I have cared for and who return love to me. These are all things that connect me to most to this universe. For some, very clearly, it's God or religion. So those connections and meaning of life. What is meaningful in my life for me? For a man, it may be getting more and more and more money at that time, possibly not towards the end of life. But there are people who hang on to the money to the last moment. I am not going to be judgmental about it, but any problems where the values are challenged, the connection is broken, or the meaning of life is questioned, there the person is likely to be in agony. Can I give you an example? Okay, who do I see in front of me? Arvind. Arvind, where are you from?
Mumbai.
Oh, Arvind, do you have grandparents in a village somewhere?
No, sir.
Parents?
Yes, my mother is close by.
Where?
My mother is in Mumbai, close by.
Okay, close by. Now, just hypothetically, let me bring up this situation where the parents are living in a village. quite far away. Arvind gets worried. They are getting old. And if they fall and get a fracture, who will be there to help them? So many worries. You, Arvind, nags your parents so much. And finally, they consent to come to you to live with you in Mumbai.
Yes.
And you bring them to your apartment in 34th floor in a big residential complex. You lock them up in the morning. When you and children go to school, you and your wife go to work, and tell them, Dad, Mom, whoever knocks, don't open the door. In Mumbai, it is not safe. They have lost their world. They are disconnected. It's very likely, if they are elderly, that in 24 to 48 hours, one of them may get delirious. They may be seeing dead ancestors. That's one kind of spiritual anguish, is that anguish of disconnection. Similarly, disconnection with anyone. Somebody is, many of you would be strong believers in God. You have always believed God will take care of me. And then you who have lived a good life find that you are in this desperate situation. There seems to be no way out. And sometimes a question will come up. Why did my God desert me? That can be a very painful thought. Especially if you start thinking, what God? There is no God. God is only with the rich people. And then you lose your support system. So just 2 examples. 3. Suppose a person, elderly person, or anybody feels, nobody wants me. My children don't care for me. Why am I alive like this? There's no point. Death will be better. So I gave you some examples where your values are challenged, your connections are lost, and meaning of life is lost. It may be related to God and religion. It may not be.
Thank you, sir.
Welcome.
Anybody else have any questions?
Hello.
Right. Okay.
Dr. Surajit?
Yeah, actually, I want to ask another question, sir. What is the
Yes.
maximum dose of morphine?
We will certainly come to management of pain on another occasion, but then there is no harm in answering it, hearing it a second time. Doctor, there is no upper limit to the dose of morphine. Unlike most other medicines, the dose of morphine is dependent on the nature and degree of pain. The highest dose of pain that I have given, it was to a 17-year-old girl with a fibrosarcoma rapidly growing. You on rounds today, you see it. Tomorrow, you see that it seems to be twice the size. And in her, we used as much as 250 milligrams 4-hourly. If that is the dose required to treat the pain, it will not cause respiratory depression. It will not cause undue drowsiness. When I am not in pain, if I take 5 milligrams, I will be drowsy. That person may not. Okay, that's one answer. The other thing is, most of our patients, majority of our patients with cancer pain, generally manage with 10 to 30 milligrams of morphine 4-hourly. So if somebody's dose keeps on going up, you start asking, like Smriti asked, is there another issue? Is there a social issue, emotional issue, spiritual issue? You need to explore a little more.
So there is a question about social pain. Can you explain the social pain?
One thing I explained, partly social pain was also financial pain. No money. You have prescribed your medicine. You have decided that this man has bony pain. He desperately needs ibuprofen. You have prescribed pantoprazole and ibuprofen. With the only money he had, he has bought it for 2 days. He goes home. You have asked to take it after food and told never take it on empty stomach. खाना कहाँ से आ गया? No money. One example of financial issues causing pain. But it is also about the suffering caused by social relationships. Haven't you seen women with serious illness deserted by husbands? Happens all over the country. Maybe a bit less in Kerala, but here also it happens. Not infrequently at all. What would that woman feel? Worthlessness, hopelessness. What will that do to any of her physical pain? So issues with relationships, quarrels between couples. Let me ask you. Sorry, who asked the question? Geetika. Geetika, let me ask you. When you are a bit stressed, or when you are in pain, if you ever get a headache or a backache, when you are in pain or when you are in stress, are you a bit irritable? Dr. Rashmi Shirali is smiling. I cannot see most people because my gallery can show only a limited number of people. And Dr. Rashmi was also gently nodding. Yes, we are all irritable when we are in pain, when we are stressed. And when you are irritable, you show your irritability to whom? To your boss, Dr. Rashmi? To the head of the institution? Never.
No, to the
Almost
ones who are
never.
closest to you.
Closest to you who are safe.
Ah, okay.
If you have a spouse who will hit you back, you won't. Then you will show it to your children. That's human nature. We come out with anger with people who are closest to you. So when you are in a lot of suffering, more of relationship issues come. And that adds to the suffering. That's part of social pain, issues related to relationships.
Sir, how do you address spiritual pain? That was one of the questions.
So we mentioned maybe there are other questions, but Raju, any question that doesn't get answered in the session, I'll have to prepare the answer and send it later. So this is not an easy answer to be given in 1 minute, but let me take 2 or 3 minutes and try to do my best. If I have my values challenged, my connections broken, or my meaning of life questioned, how will you know? You can't come and give me a question, hey, have you had your values challenged, connections broken, or meaning of life challenged? Well, doesn't make any sense. What is necessary for one of you to sit beside me? You may not be the busy doctor, your social worker may actually do it much better than us. Sit beside you, get to know me, understand me. And if you have the time, you may try this only with your grandmother, who is lonely much of the time. Grandma, tell me the story of your life. Ladies and gentlemen, I assure you, if you do that to your grandparents or even to your parents or an uncle or aunt, you will be surprised how little you know about them now. They will tell you the stories. Their experience will tell you what their values are, where they feel connected, and they will say, Betty, just let me go back to my village once more. I know I am ill. Doesn't matter. Take me back once. Let me go to that temple once more. That church. These may be the things that they will speak. Finding the connection, rebuilding what can be built. That may still not give enough meaning to. There is another magic therapy for meaning of life and connection. Give them love. I know there was no chapter on love in textbook of medicine or surgery or anyway. That's a missing chapter. Convey to them that you care for them and have 3 conversations, not with your rigidity of your degrees and stethoscope. The moment the stethoscope goes on, your muscular spasm increases. Remind yourself that you are a human being. That is a human being. Relax, sit beside the person, lay a hand on the hand and say, I see you are suffering. I am here to help you as much as I can. With that, you have conveyed that you care for that person. That's what I meant by give them love. And on the 3rd day, they may again tell you, I thought God had deserted me, but He hasn't. He sent you to look after me. That is spiritual care.
Okay, thank you, sir. I think there is one question which I think I'm not very clear. Can you explain what effective drugs for uh, for treating suppression of tumor enlargement?
But I'll tell you one thing. In most tumors, the tumor is comprised of the tumor's tissue and edema. Wherever there is a foreign matter, in this case to the body, a tumor is a foreign matter. There is reactive edema. You give corticosteroids, the tumor shrinks. Not because cancer is treated, except in a minority, but mainly because the edema reduces, particularly in hepatic swelling. Significant reduction of the pain can happen. In a nerve compression, dramatic reduction of pain can happen with corticosteroids.
Okay. So we will move on to the patient story. Rajlakshmi, can you share the patient story? And this will be presented by Dr. Ranjita.
Sir, Dr. Ranjita will be sharing from her end. That is what she said. So, Dr. Ranjita, can you share the screen? Dr. Ranjita, are you able to share the screen?
Yeah. That is a PPT.
Doctor, can I share it from my end then?
1 minute, I'm just trying to share.
Okay, sure.
Are you able to see now?
Yes, doctor, we are able to see it.
in slideshow. Should I on the camera?
If possible, yes, ma'am. If your connectivity is not good, then you can remain with the video off.
I'll just try, ma'am.
Okay.
Dr. Ranjita, you can start.
Yes, sir.
And keep the microphone near to your mouth. It's feeble.
Good afternoon, everyone. Am I audible?
Yes, you are, ma'am. Speak a little more louder.
Okay. Good afternoon, everyone. I'm Dr. Anjita Mehta, working at Seema Dental College. Yeah. So today's patient, she's a 50-year-old female, and she was diagnosed with moderately differentiated squamous cell carcinoma of the left gingival sulcus involving alveolus and extraoral skin also. Of T4, TN2, 0 was given. So she complained of a growth in her left inner side of the cheek since 2 months, and she also had extraoral swellings.
Doctor.
Dr. Ranjita, can you also change the slides? You are keeping the first slide.
It's not. Achha. I'm changing, sir. For me, it is changing. I don't know.
Doctor, I think I can share it from my end, and you can just say next for the slides. Doctor, can you see the slides?
Yeah, you. Okay.
Okay. So you can continue, sir, doctor.
So the patient presented with a growth in the left inner side of the cheek since 2 months, and she had history of extraoral swelling since 1 month. Next. So, so according to the patient, it was initially small and gradually progressed to the present size. It was associated with pain, which was gradual in onset, moderate intensity, and it was localized to the left lower third of the face, and it aggravated on chewing, opening, or while talking, and it relieved on taking medication. She also said that she had bleeding from the same growth since 2 months, and the extraoral swelling was since 1 month, and there was a pus along the sinus opening extraorally. And she also complained of reduced mouth opening since 1 month. Next slide, please. She had a habit history of betel nut, tarifnet along with tobacco, and she achieved 6 times a day, 60 years. A menstrual history, she had attended menopause 3 years back. She didn't have any symptoms. Next slide. General physical examination was moderately built, nourished, conscious, and cooperative, well oriented towards time place and as a person. All the vital signs were normal. Next. Yeah, this is the extraoral images of the patient. You can see there is a facial deformity on the left side, and there's also depigmentation, as well as you can see the scapes, sinus opening. The intraoral pics, where you can see the extension of the lesion on the left side in the buccal vestibule. That is the place where she used to keep the quid along with the tobacco. So on palpation, there was bleeding also in this ulceroproliferative growth. Next. So what are the treatment and significant investigation was done? So although as there was, the lesion was since 2 months and there was bleeding from the growth, it was a clear sign of malignancy. So to assess whether the underlying bone was also involved, a radiograph of orthopentagram was done, which revealed a certain amount of bone loss in that particular region. Along with that, blood investigation, incisional biopsy was done to rule out histologically whether it was malignant, and CT scan was done. They had even gone for MRI to see the involvement of the lymph nodes. Next. Next. Yeah. So in the treatment, they had the tumor along with segmental mandibulectomy on the left side, and ipsilateral functional neck dive was done along with a skin graft. Furthermore, after the patient was stable, the patient was advised for chemoradiotherapy and prosthetic. Next, Rajneesh. Yeah. So now coming to the psychosocial aspect. Now, as soon as the patient came to know that she has a growth which is turning, which has already turned into malignancy, and she has to go through certain procedures, treatment, and which would require a lot of financial support. So the patient the patient was a bit anxious due to the fear of suffering from debilitating condition. And still today in our society, when we just say that somebody is having a cancer, there is a social stigma attached to that. It's still a taboo over there. Most of the people are not much aware that these can be treated, and all cancer doesn't lead to end of life. There were again family issues running into the patient's mind, as they were from low socioeconomic background. The female had 2 sons who were already married. They were basically farmers. Her husband was at home not working, and she had a daughter for whom she had to get married. And just knowing that she has cancer, she was like anxious about this. The other factor could be isolation from the society. As I told you, still today people don't have the much knowledge or awareness about this. So there could be a social isolation. People might not take you as a healthy individual, right? Next would be financial constraint. Again, spending so much on the treatment aspect, the investigations. As they were from a village, it was quite difficult for them to travel, gather the travel expenses, staying over there. So all these things are attributed to a lot of anxiety in the patient. And moreover, as the lesion was in the face, the surgery has to undergo, and that would result in facial deformity. So even aesthetic concern, especially being a female, would again be one of the concern. Next. So operatively, like as it was secondarily infected, clavum, metronidazole, painkillers, and were given IV. And post-operatively, as the pain was more, the patient was put on tramadol. And maybe the tramadol dose was more, as one of the side effects of tramadol is nausea and vomiting, patient was also given on them. So after that, the patient was sent to chemoradiotherapy. Now, during chemoradiotherapy, again, palliative care is also required, because the patient undergo a lot of oral changes during chemotherapy like mucositis, stomatitis. During radiotherapy, the patient, along with these two, the patient might also suffer from, as the area is irradiated, all salivary glands are nearby. So they might be affected, and that might lead to xerostomia, dryness of the mouth, further leading into again fungal infection or this thing, stomatitis, right? So all these parameters have to be taken care of. Next. Now, main concern as a doctor, the main concern for us would be breaking the news to the patient. So, as we know that we have to make aware to the patient that what he's truly suffering from. That doesn't mean it has to be conveyed directly that you are having a cancer. It could be said that you have a growth in the oral cavity that might extend furthermore, and later on the treatment will be more difficult. So it is better like it can be done now and you might get well, right? Counseling the patient, right? So as they are from a village, they don't know how to go about it, whom to contact. So counsel the patient to contact, give the patient NGO associated with this who might help the patient financially or even in the treatment part also, right? The patient has to be explained entire procedure, and even the hospitals which have free chemoradiotherapy or surgeries, that hospitals can be told to the patient where free treatment can be done. So half of the patient burden is decreased because of, like, if you give them a proper guidance regarding what they have to go to do in for the future management of the condition. After going all through this, again, because the surgery would lead to disfigurement of the face, right? And when you go for radiotherapy, the patient's oral cavity was already periodontally compromised, all teeth were mobile. Before radiotherapy, entire extraction of the tooth was, total extraction was done. So it was rendering the masticatory function, right? So to be after radiochemotherapy, the patient has to be nutritionally sufficient. So the patient has to have a proper diet. So for that reason, the masticatory function has to be restored, so the patient might have food properly and come to a normal this thing. Other than that, improving aesthetic appearance, definitely aesthetic appearance plays a very vital role in today's scenario, because we live in even in today's scenario, we have the discrimination for color, right? So when it comes for facial disfigurement, yeah, it is one of the prime concern, right? So all these things has to be totally explained to the patient. Rajalakshmi. So I just have this post-op pics of the same patient. This is after the chemo and the radiotherapy. The patient has been placed skin graft. Next. So as the patient total extraction was done, and you can see the OPG, right? There was a segmental hemimandibulectomy done. So prosthesis was a bit difficult in this patient because your dentures, they get stabilized over the bone because there was already no bone in that area. Next. So somehow our prosthetic department, they managed to get our prosthesis done to this patient, and you can finally see that the patient, the masticatory function were restored, and to certain extent the facial deformity was not that obvious. It was quite better than previous one. Next. So now for discussion points, like does this patient requires palliative care? If yes, what all aspects of palliative care has to be dealt about? So I think this will go for discussion, right?
You can read out the questions here.
Does this patient require palliative care? If yes, then what all the aspects of palliative care has to be dealt?
Thank you, Dr. Ranjita. So we have a woman with malignancy of the cheek, and she underwent chemo radiation as well as surgery. So the first question, there were two questions. Does this patient need palliative care? And if yes, what all aspects we can provide palliative care for this patient? So I request the participants to give some comments on these two questions.
May I speak?
Yes.
Can you hear me? My name is Dr. Nilima. From the question, yes, she does require palliative care. Of course, she does, because this is a huge issue, both medical as well as emotionally for her. And all the aspects like her palliative, if there's any pain that she needs, she'll need palliative care for that pain relief. The emotional aspect associated with this, as was described during the case, both that she's a woman, there's such disfigurement to her face, what it means to her whole aspect, personality will be affected. So that also we'll have to give some palliative care for that. Then socially also, as mentioned, she was from as was mentioned, she was from a lower socioeconomic status. So even the finance would have been a problem for her. So all that would add not only to the pain and the distress, not only of the disease, but the thought of the surgery and what is going to come further. So all these issues, these all aspects would have to be dealt with for her. And spiritually, we talked about a lot of spiritual pain and spiritual effect also today. I don't know about this patient, but many people do have a spiritual aspect as well, and they'll have that fear of why has God abandoned me? Why has this happened?
That is also there.
So even that would we have to be.
Thank you. Those are very valid points. Anybody else want to contribute?
Good afternoon, everyone. I would like to add up to what ma'am had told already. Is that, yeah, definitely this patient requires palliative care. The other most important thing is from a aesthetic point of view, if you see, even after the surgery, I think the patient would be socially demoralized that her teeth are all lost and the jaw is taken away and her facial outlook has been completely changed. So that would also make the patient feel low and not able to move, socially move with people or come out, and it would also has to be taken care of actually. I would think that also palliative care includes that as well, that we need to even take care of that aspect of the patient. Is the treatment and the other aspects are more important, that may come as a priority, but it is also essential that she's been found some manner in which she's gets a replacement, reconstruction, all that, and she's been counseled well enough that she'll be able to come out and move with people and able to lead on with her life.
Yeah.
Yeah, ma'am, you are
Yes.
absolutely right. And sir, can I? So that was the reason, because after the chemoradiotherapy, after I think 1 year, she came for prosthetic rehabilitation. So even that, even with that agony, she was ready for prosthesis and to make herself look better. And right, so we need to put in a positive feed into the patient. Yeah, it can be dealt with. All cancer doesn't lead to end of life.
Yeah, I have a question to Dr. Ranjita. This is Dr. Uma. I just wanted to know what sort of medications or analgesics were put for the patient during the diagnosis or during the procedure or post-procedure. Can you just let me know? Or...
Actually, I put in the slide. We diagnosed, we did the investigation, and the patient was referred to oral surgery department. Ma'am, initially, as she was in pain, and it was secondarily infected because she had this extraoral sinus opening and all, right? So she was put on IV, this thing, Metrogel and clavum, that is amox and clavic acid. And painkiller, I think they started with this thing, diclo and paracetamol combo, ma'am. But later, after surgery, they had put her on tramadol.
Yeah, thank you, Dr. Ranjita.
Anybody else has any comments?
Excuse.
Just one comment, sir. I felt the post-operative this thing. We have written tramadol and Ontam SOS or something. So I think yes, Sir also mentioned now that we should not do it. We should do it by the clock. So I think instead of SOS, post-operative should be, maybe 6 hourly or whatever, 4 hourly or 8 hourly. So I think that should be a better thing. I mean, this is just my opinion.
Okay.
Yeah, thank you. If the patient has continuous pain after the surgery, then definitely it needs to be round the clock, no doubt. Any more comments?
Yeah, on this treatment part, tramadol SOS and Onden SOS, I disagree about this because I've read somewhere tramadol and ondansetron should not be given together because they block each other's effect. And this is a routine practice, and we just hike up the dose of tramadol and ondansetron, but patient doesn't get any benefit of it.
Tramadol has dual mechanism of action. It acts like a opioid, that it acts on opioid receptors. In addition, it also acts like tricyclic antidepressants. That is, it blocks the reuptake of, inhibits the reuptake of noradrenaline and serotonin. Whereas ondansetron is a 5-HT3 blocker. I don't know whether it may cause some problem with serotonin inhibition, but even if that happens, it can work by the mechanism of opioid receptors, and its a predominant mechanism is by action on opioid receptors. Tramadol is supposed to be a little better for treating neuropathic pain because of its reuptake inhibition of noradrenaline and serotonin. But from a practical point of view, it is not considered as a medicine to treat neuropathic pain. It is only second line medication. So tramadol can be beneficial for treating pain, even if you give ondansetron. But I am not very sure about what is the interaction that is going to happen with tramadol and ondansetron.
Okay, sir, I will try to share the paper regarding this, then probably it will help everybody.
Yeah.
I have a question to Dr. Sunil.
Yeah.
So the patient, this patient, do you think she had only nociceptive pain or neuropathic pain or both, sir?
Can Dr. Ranjita describe that quality of pain and the distribution?
Wasn't probably discussed. Yeah.
Yeah, sir, it was localized to that particular area, and it was it was sharp shooting pain, and it was nociceptive only, sir. I don't think it was neuropathy.
Okay. Localized pain usually occurs as a result of nociceptive stimulation, but shooting pain is a feature of neuropathic pain. So I think we would need more. Sorry, somebody has unmuted. So we need more pain assessment in this patient. So definitely this patient needs palliative care. From a palliative care point of view, you have to provide all the aspects, all the domains of suffering, like physical, social, psychological, financial, and spiritual care for this patient.
So I have one doubt, sir.
Yeah.
To maybe Rajagopal sir or Sunil sir can help me out. So if a patient, like it's a cancer patient, but not in the very severe stages, maybe stage 1, stage 2, which is able to undergo treatment and recover from it and have a better 5-year prognosis, even those patients should be included under the palliative care? Or is it only patients who we feel that the treatment is not going to be fruitful, or patient is not going to have a very better recovery or prognosis. Only those patients will be included in palliative.
Okay, just now all of us told that patients, uh, not only the physical problems, but also the psychological, social, financial, and spiritual problems are addressed in palliative care. So patients, when they are diagnosed, they will, suppose this patient, I don't know how it was diagnosed, maybe sometimes with an ulcer or with a pain, and with physical problem they are approaching a doctor, and then they are taking biopsy and they diagnose. For this patient, there were physical problems, but when probably when she knew that she has a cancer, she has then she develops psychological problems, and as she is very poor, financial problems, social isolation, all happens. Why did God give this to me? So spiritual problems. So all this occurs at the time of diagnosis. So it is not depending on the stage of the disease, but it is depending on the problems or suffering that the patient facing. So we can provide palliative care from the very early diagnosis itself.
So that means most of the diseases that the patient come with us, the palliative care should be included from the start.
Yeah.
It doesn't have to be something very serious.
That will also depend on the resources that you have. Suppose a patient diagnosed with CKD, chronic kidney disease. This patient has many problems, including sometimes there will be pain. From a social point of view, he might be poor, so economical problems. But this patient will be mainly going to the person or a nephrologist. Yeah. But along with that, if you can help with the resources like maybe he needs dialysis every alternate days, or he needs some psychological support. So if you have the resources for providing this, yes, you can do. But this will depend on the resources that are available to you. But as a general rule, we say that palliative care should be provided from the very early diagnosis. But that will not be possible all the time for all the palliative care units. And that also depends the patient awareness as well as the doctor who are referring the patient to you, because many patients are not referred at an early stage to palliative care in many places.
Thank you.
Sir, can I ask questions?
Yeah.
In this case, do the family need support from palliative team due to the family will felt suffering because the patient problem? Thank you.
Yeah, actually palliative care is also, we should aim to improve the quality of life of patient, not only the patient, but also of the family. So we should be able to address the concerns of the family also. So if they have, they're also suffering maybe from financial problems or from the other health related issues or something like that. So if this also depends on the resources that you have. So we have to include the family, there is no doubt, but it will depend on your resources also.
Dr. Sunil, sir, I have a question for you.
Yeah.
Regarding palliative care. Palliative care, from what I understand, is not just for cancer patients. It can also be for patients with chronic diseases, which will
Your
ultimately...
voice is breaking.
Palliative, can you hear me now?
Yeah.
Is palliative care only for cancer patients, or is it for any patient who may have a chronic disease which will be with them for the rest of their life. Like, say, like you had mentioned, a chronic kidney disease. He may not
Yeah.
get cancer, but he will die of the chronic kidney disease after this multiple dialysis after many, many years. So is palliative care something that can be offered to them also, or is it only for cancer patients?
Actually, any patients with reduced quality of life.
Okay.
So if you take that chronic kidney disease or congestive heart failure or anything like that, CVS, so all these patients have reduced quality of life. They will not be able to enjoy the life like the other people do. For example, paraplegia. These patients will live long, but they cannot enjoy the life like others. So they have a reduced quality of life. So in such instances, we have to provide palliative care. Palliative care does not depend on the diagnosis, but it will palliative care can be provided as per the need of the patient.
Okay.
Okay, it is not a diagnosis dependent.
Not diagnosis. Okay, thank you.
So I think we have to wind up the session now. Thank you all for your very interactive session, and thank you, Dr. Sanjit. Thank you, Dr. Ranjita, for your patient story, and thank you, sir, for being with us today. Thank you all, and we will see you on next Monday. Rajlakshmi.
Sir, Rajalakshmi is not here. I am Arun here. So I request everyone to please fill the feedback form and submit it before we leave. It is very extremely important to us to evaluate our program. Okay, thank you everyone, and we are signing up. See you next week. Thank you.